Ooh,
I think we went. Did it go?
yes. Thank you for doing that.
Yeah.
Good afternoon to everybody. It is 12 noon, so I want to say hello and thank you so much for joining today's CMDA meeting. It's Tuesday, November 7th. I'm Sing Pallet, the president of CMDA, and today we have our vice president of CMDA, Dr. Rebecca Jackson, who will be hosting the meeting. But just before I turn it over to you, Rebecca, I just want to remind everyone to please sign up to go to the conferences this year. On March 9th is the National AMDA Conference, PALTC 24. It's going to be held in San Antonio, Texas. And we were just talking about how several people from Colorado will be presenting at this national conference. And then also save the date for April 19th, right here in Denver, Colorado, is our CMDA annual conference. So we hope to see you all there too. Well, Rebecca, I'll go ahead and let you lead today's meeting.
All right. Well, thank you. I appreciate everyone's patience as I am learning how to help sing out. Basically, we were talking about being the president's assistant today. So that's what that's what we're doing. So we'll get started. I think I saw Chad Fear join us. We were going to start off with some community updates today. We always appreciate these because it kind of gives us a pulse on what's going on in our area. So Chad, if you are available, we would love to hear from you this morning. I think you're talking. I can't hear you.
You're muted, Chad.
I can't hear you, Chad. Let's see.
I can't either.
He doesn't look like he's muted.
Not on our end. Maybe on your computer, Chad?
Chad, you may have to disconnect yourself from the external monitor. That's what I had to do yesterday in a meeting at the office.
Poor Chad has been talking for the past 2.5 hours. He's probably tired of it.
I mean, we could.
No.
Chad. We could
reset your speakers in your settings.
He usually just jumps right in, so.
I know. Your computer's being tricky for you today.
When you go to the office, it kind of messes up our computer sometimes when we plug them in there. Then they get messed up.
Yikes.
All right. We can let's give Chad a few minutes to figure it out because I believe Mariah Payne from Telligen is here. So Mariah, if you're available, we could let you go and you can give us some Telligen updates.
Great. Thanks, Rebecca. Could I share my screen if that's okay?
Yes.
One more time.
Oh, Chad, you're ready. Chad, I just ruined your intro. I gave the floor to Mariah.
Okay.
Sorry.
You should be good to go, Mariah.
Okay. Thank you so much. So as mentioned, my name is Mariah. I'm a senior quality improvement facilitator for Telligen. And I just wanted to share a couple of the updates that we've been sharing with our communities. And so just a quick overview of who Telligen is. We are a Quinn QIO, so Quality Innovative Network, quality improvement organization. And our goal is to improve the efficiency, effectiveness, economy, and quality of services delivered to Medicare beneficiaries. We provide technical assistance and convene learning and action networks at no cost to support healthcare quality improvement. And so recently, we have been providing outreach to our enrolled nursing homes related to emergency preparedness and reducing unplanned transfers and rehospitalizations. And so that kind of brings me over to our emergency preparedness assessment. And so we created this assessment in alignment with the Center for Medicare and Medicaid Services emergency preparedness regulations. The assessment serves as a comprehensive checklist to evaluate emergency preparedness, and it takes about 15 minutes for completion. It reviews the 5 core elements of EPP, so the risk assessment, which occurs every 12 months, emergency plan, communication plan, training plan, and testing plan. And then when nursing homes are preparing to complete our emergency preparedness assessments, we recommend they reference their facility's emergency preparedness plan for best results. And so once the assessment is completed, nursing homes will receive an email with a checklist that contains trusted resources to assist them with addressing any gaps identified in their plan. And we also encourage them to reach out to engage in one-to-one technical assistance for their emergency preparedness plan with their direct point of contact, along with we could have our subject matter expert in emergency preparedness join that call as well. And so for nursing homes that are part of larger organizations, we can provide aggregated assessment results for broader improvements and impact. And so to do this, we wanted to engage corporate leadership. And so we created a corporate gap analysis. The analysis provides information based on the 5 elements by category and has corresponding questions within each section. And the gap analysis will show an overview of the responses from each of the corporation's facilities. And the gap analysis will show compliance rates based on the response from their nursing homes. And from there, it just allows leadership to identify which elements are most successful and maybe which ones may have an opportunity to review. And then with this information, leadership can prioritize which gap to focus on first. And we've also incorporated the completion of our emergency preparedness assessment as part of our criteria for our best in class recognition award. And so this award is an extension of our COVID-19 Blue Ribbon Vigilance Award, which was established back in November of 2021, and it was to provide recognitions to nursing homes for their efforts that they were making to prevent the spread of COVID-19. And so right now the criteria is that they have a staff up-to-date vaccination rate of at least 25% and a resident up-to-date vaccination rate of at least 80%. And so with the expansion of this Blue Ribbon and COVID-19 Vigilance Award, we created our best in class. And so the best in class focuses on a facility receiving the Blue Ribbon Award for at least 3 out of the 4 quarters, our focus on emergency preparedness, safe staffing, so infection prevention and control training within the facility for frontline and management staff. And then the T stands for transition. So focusing on reducing emergency department visits for either long stay or short stay residents by 5% or be within the top 25% of Telligen's enrolled nursing homes. And so through the data that we have gathered for the Medicare and Medicare fee for service claims data, we've identified readmissions to hospitals within 30 days of admission as a challenge for nursing home residents across the state. More specifically, the top reason for readmission from the data was sepsis. And so as a response to this information, we are currently actively providing outreach to collaborate with our nursing homes on this area. And then lastly, I just have, this is our Colorado nursing home team. Every nursing home and corporation has a designated point of contact here at Telligen. So if you do have any questions, please feel free to reach out and we'll also be contacting you guys if anyone has any questions. But I will hand it over to Rebecca. Thank you.
Thanks, Mariah. I feel like sepsis is always the readmission. That is definitely always number one. So we appreciate all your help trying to solve that problem because it's something we all have. So, all right, Chad, Fear, I'm so sorry. I stole your platform. So I'm going to give it back to you and you can give us some CDPHE updates for us. Thank you.
Right. No worries. And can you hear me now? Okay. Yeah. So not a whole lot to share with you today. But I did want to kind of bring to your attention some IJs that we've had for the month of, I guess it would be October. There was an IJ for protection from abuse by others and another for non-pressure related wounds. And in both situations, the facilities failed to follow their investigative process or their protocols in this instance for wound care. And the deviation was such that it created serious outcomes for these individuals. Pardon. I did also want to share with you some trends that we're seeing, and these are preliminary trends. We don't have a ton of data, and these may change, but at least up to this point in our federal fiscal year, we're seeing some trends in discharge citations, abuse reporting and investigating, infection control, kitchen rehabilitation. That's kind of a new one for us in terms of our frequent list. The pre-admission screen resident review process, wounds, both pressure related and non-pressure related. And then we're seeing some citations around the pneumococcal vaccinations. And what this seems to be is folks are getting the first in the CDC recommended series, but there's not a follow-up with the appropriate second vaccination. And in some instances, it looked like there was some documentation issues where perhaps it was done and not being followed through with in terms of documentation. And in other instances, the facilities were really unaware of their need to continue to follow up with this requirement. We spoke about this in an earlier meeting, and I'll bring it to your attention as well. Sometimes you have situations where you're left without a nursing home administrator, and there's an ability for the director of nursing to apply for an emergency administrator's license. We've had some situations similar to that, and I want to remind everybody that in that process, that the facility still needs to provide a full-time DON or full-time DON coverage for the clinical care of the residents in the facility. I think that's probably what I've got to share with the group. If there are any questions, I'll take them. If not, I'll listen to the rest of today's presentations.
Awesome. Thank you so much for that update. Does anyone have any questions for Chad or for Mariah before we move along?
Chad, real quick, what were the infection control, the main issues that just covers so many things?
Dr. Gahm, it does. And kitchen the same way. There's so many different ways to get a citation. Kind of boots on the ground, it's housekeeping stuff. Sometimes it's wound care that we're identifying, breaks in infection control. A lot of those kinds of citations seem to focus around the vaccinations and some of the documentation that's held for vaccinations, both COVID and other, basic hand hygiene. It really kind of, there's a trend around basic hand hygiene.
Okay. And then one other question. You talked about the pneumococcal vaccination and not following up, and I guess I'm a little confused. If you get a Prevnar 20, you get that and you're done. But if you get the 15 a year later, you have to get the pneumococcal. Is that what you were referencing, more the 15 and follow up, or?
Dr. Gahm, it is.
Okay.
Hey, this is Christine Laraca. I'm just glad to join. If you all are anything like me, I have to every time go to the CDC site for the Pneumovax recommendations. I don't know if there is some simple site, simple tool, carry it in your pocket, because it's complex. There's a lot of if, maybe, when, depending on. And so if there's some way that Telligen can help with that, I just want to acknowledge that I personally find it very challenging.
Yeah, Christine, do you mind if Rebecca, answer that question as well?
Yes, go for it.
I totally agree, Christine. I also, so there's a little cheat sheet table that I think it was actually put in the MMWR, and we can send it out to all of the CMDA community. And I do carry it around because I also have to double check myself. So that's a great tool, and we're happy to share it.
In the chat box, Allison suggested that there's a CDC website has an app with an algorithm to decide who's due for what.
That's helpful as well, since we always have our phones, it seems, on us. So, all right, perfect. Any other questions? All right, if not, then we'll be moving along. We're gonna have Jenny Albertson from CHCA. She's gonna give us a presentation talking about provider responsibilities for involuntary discharges in long-term care, and some updates around that space. So thanks for joining us today, Jenny.
You bet, my honor. Thank you so much. I will make this as expedited as possible, but it is kind of juicy material for you all. So pay close attention and you're going to get the slides. Involuntary discharges are really integrated with physician documentation and choice and involvement in the process. And my big fear is that we have a disjointed process in a nursing home and it sets us up for failure or for survey deficiencies. So this education is meant to arm you and equip you to make it a solid process with your teams. It doesn't make it any easier. I will not promise that, but it'll give you clarity and regulatory references so that you have an exact description of what's required of you. So let's get into it. First of all, what's an involuntary discharge? It's distinguished from a resident-initiated discharge. So the community specifically is initiating the discharge. There is a really handy-dandy ombudsman definition of this on a flyer for Boulder County that they created out of their ombudsman program. I reference this when I'm trying to explain to people. This is the idea. The discharge is when a resident permanently exits the facility and goes into the community, not goes to a hospital necessarily, and the facility requests that they leave or they choose to have the resident leave. A resident-initiated discharge includes a transfer as well, when the resident or, if appropriate, the representative gives written or verbal notice of their intent to leave. A resident just saying they want to go, they want to return to the home or the community, or they're an elopement resident, that is not considered to be a notice of intent to leave the facility, particularly if they are cognitively impaired. That's actually the caveat that's put into the regulatory language. I think sometimes we would like to interpret that as a desire to go, but if they are impaired, they are not considered able to make that choice. So why would you need to discharge a person against their choice? So level of care need does not match the care the community can provide, too much or too little. The resident becomes a danger to the health and or safety of others or themselves. Non-payment, this is the piece that I'm not really going to address with you all because it's the only piece that does not require your intimate involvement or documentation. Non-payment cannot, just FYI, be due to a Medicaid pending status. So if you're curious, oh, we have $80,000 outstanding for this resident, why are they still here? That's really an administrator decision. And if it is a Medicaid pending resident, they may have their hands tied completely if the process has just been going on that long. Or the last, of course, is the facility is closing or loses its license. There's pretty much an involuntary discharge happening for everyone. All right. A change in level of care need is really where we need to talk about. The resident improving sufficiently to go to assisted living or an independent living environment, return to home, can he or she get what they need at a lesser level of care? That's where your documentation is going to be focused. You're going to enumerate the needs that they once had that they no longer have. Or a resident declines to the point of needing more care than this community can actually provide. Examples would be, we are not ventilator equipped here, or we don't provide a negative pressure air environment. Perhaps they need an individual sitter 100% of the time. That was expressly stated in our admission agreement. We do not provide that level of care indefinitely. If you need a secure unit and don't have it. Those are all good examples. This is different for AL, by the way. So if you're operating in both sides of the spectrum, you're going to have to reference the AL admission criteria to get into that declination of the decline of care level. So declination of care or treatment. If a resident says they don't want care, we deal with this a lot, right? A resident declines treatment, it cannot automatically equate to grounds for discharge unless it makes you then unable to meet the needs of the resident or protect their health and safety or the health and safety of others. The facility has to be able to demonstrate that they have information about the risks of the refusal of treatment. So this is, again, getting to your documentation elements. And the staff has to conduct the appropriate assessment to determine if care plan revisions could allow you to meet the resident's needs. So this is kind of go to the nth degree, go to the end of the world and back to try to find a way to allow them to remain in place. This is how the regulatory language reads, and this is the tag where it lands if we happen to have a discharge approved improperly. Sorry about that, I'm scrolling. The facility has to permit a resident to remain in the facility. This is language that was updated and changed in October of 2022 to make it more stringent. Basically, when we admit a resident, it's an adoption, it is not foster care. I don't care if they're here short-term or not. You have to know you're going to live with that person until they decide that they are no longer living with you. And involuntary is extremely hard to substantiate. The transfer discharge needs have to be one of these elements, and it's the ones that I went into earlier, but I wanted you to have the exact language. Emergent transfers to acute care, this was updated in October 2022. It became a lot more stringent. So residents who are sent emergently to the hospital are considered a facility-initiated transfer and involuntary technically, even though we don't couch it in those terms. It's facility-initiated, not resident-initiated. The resident's return is expected unless we have something that says that they cannot return. So residents who are sent to the emergency room have to be permitted to return to the facility unless the resident meets one of the criteria on the previous slide, under which the facility can initiate an involuntary discharge, okay? In a situation where the facility initiates that discharge while the resident is in the hospital following an emergency transfer, you have to have evidence that that the resident's status is not based on his or her condition at the time of the transfer out to the hospital. It has to be that they are unable to return because of their needs upon their ready time to return. And they have to meet the discharge criteria at that time, not when they were sent out. Once they are stabilized, they have to meet an involuntary discharge criteria, and then you have to go through the 30-day process, 30-day notice process. When a resident is temporarily transferred on an emergency basis to an acute care facility, it's considered to be facility initiated. Here's your regulatory reference if you want to get into the actual text of the document. A notice of transfer for a facility initiated emergency transfer still has to be provided. The resident or the resident representative has to receive some notice of why they were sent to the emergency room in letter form from the community. I know it sounds strange. This is not going to come from you, but you might want to work with your teams to make sure that that documentation gets done when you have an emergency discharge to the hospital. Copies of notices for emergency transfers still have to be sent to the ombudsman, just like involuntary discharge notices, but they have to be sent when practicable. It's like you can batch them on a monthly basis, whatever you decide is practicable. But there is some notice needed to the ombudsman. All right, so when you discharge to the hospital and you refuse to readmit, you have to follow these elements. The status at the time the resident seeks to return to the facility, not at the time the resident was transferred for acute care, has to meet a discharge criteria out of those 4 elements that we talked about on that earlier slide. And you have to provide notice of the transfer to ensure they can receive complete and accurate information about the notice and why they're being not allowed readmission. The resident has the right to return pending an appeal. If there is a facility initiated involuntary discharge, they have appeal rights. This is also being added to the AL regulations, by the way, this notice of appeal and all of that. It can go up to approximately 107 days of an appeal process if they stretch it out. And you have to document the danger that the failure to transfer or the discharge would pose. So if you're saying I can't readmit them because I can't care for their level of care, they need ventilator, etc., that's easy enough to substantiate. If you're saying that they are continuing to be violent and so forth, whatever the reason was for them to be a danger to self or others, you have to document why you believe that. Sending someone to the hospital to assess might be a reasonable approach so that you have adequate material to document with. And then ensuring that there's adequate physician documentation about the potential sources and the steps you've taken to investigate why that individual has changed in their level of care need, whether it's a behavioral trigger or whatever it is that has risen to that level. This can't be a progression with no documentation of how we tried to mitigate it, for example. What diagnostics have you run? Have you proceeded through the process of talking with the resident and the representative about different approaches to care and so forth? All of that needs to be in your documentation, not just on the facility side. I did want to give you some reference to what was updated in October 2022 on the specific F tags. I'm not going to read through these. You have them for reference. This is the list of documentation regulatorily required for all hospital transfers. And not all of this is your responsibility, clearly. Your medical records person, your health information manager, blessings upon them, should be managing all of this and auditing it for every hospital transfer, but I did want you to have it for reference. And you'll note that there are several things within which you are intimately involved. So care plan goals, information necessary to meet their needs. Say, for example, you want them to see a specialist and so forth. Is that somewhere besides your physician notes? Is it an order? Have you communicated that? Has there been a dropped order somewhere that precipitated a hospital transfer? This is your opportunity to scrub and make sure you look clean in what you have done for your care interventions with this individual. All other discharge besides hospital transfers require these elements in documentation. I thought this might be useful for you because I think often you might think that your physician summary is covering everything because it's all you can think of to write about that individual. But if you are not truly documenting a summary of what they accomplished in their caregiving, receipt of caregiving while they were with you, a final summary of their current status and where they've come from, where they have come from and where they are upon discharge, reconciling pre-discharge medications with post-discharge medications. I think we leave that to our nurse case managers, our MDS coordinators even, and expect them to audit that for us and say, oh, we need a clarification order. I'm not sure I would trust them with all of that myself if I were in a doctor's shoes. And then a post-discharge plan of care developed with the resident. Do you have documentation of, we've spoken about this in our conversations, we've decided this is what you need to have when you leave care from this community. I apologize. There's an extra little stipulation for short stay residents. If a resident has not resided in the facility for 30 days, you still have to issue a notice of discharge if it's facility initiated, but it's not expected that you give them a full 30-day notice. In these exceptional cases, you do still provide them a notice if you can, the facility does, but it's not the same whole process as an involuntary. It was assumed that they were going to leave at a certain point. A discharge was predetermined upon admission, but you're still going to involve the ombudsman. If an involuntary discharge is completed, there are components of a notice. I wanted to make sure you had this. The main key for you here is that appropriate information is communicated to the receiving healthcare institution or provider. If they are going to a higher level of care, you want to document that you've handed off care. Here's your list of physician documentation for the involuntary discharge. We've already touched on it, but just to summarize what is in the regulation. And then this is your role in documentation. So you do have to sign off on the notice. There should be an actual physician or attending physician or medical director line on the notice itself that says that you understand what's taking place. They are supposed to give you a copy of that. It will also be in the medical record, in the business office, to the ombudsman, like I said, and to the state. Chad will get an email. And your documentation of the transfer or discharge is completed either by a non-physician practitioner or the physician treating. Welfare and the resident's needs cannot be met, has to be touched on somewhere. Resident's health has improved sufficiently, has to be touched on somewhere. You have to meet the criteria that we're trying to target in your description. Safety, health, anything that has to do with provision of care, all types of discharge except non-payment or facility closure require you to have this note in the chart. And then the pieces for the facility to follow, I only wanted to include this for you to understand that they have to go through a long process before they can determine that a discharge is the only option. And they have to try to get the residents to consent to discharge to a place of their choosing as part of this process. You cannot issue an involuntary discharge without a discharge location. And if it's changed, you have to start the 30-day process over again. Here are all the people that get involved and get a copy. Or no, not get involved and get a copy. That's another slide. These are the people who you need to include for post-discharge plan of care, making sure you've addressed all these elements. This wouldn't necessarily be you. This would typically be your social worker or nurse case manager. This is the information they will provide to the receiving provider as a medical records person typically, or nurse case manager. And then the appeals process is described here from a regulatory standpoint. Main thing for you to know is that it's a 4-step process, and it can add a lot of time while you're waiting to discharge someone. So it is quite cumbersome and very favorable to resident rights, as you would expect. And it looks like I have some questions maybe in the chat. Any questions? Let's see. I have a question here about sexual assault and victims not pressing charges. So since our police individuals have nowhere to bring someone with our particular care needs, you are typically not going to see an arrest when you report criminality on behalf of a resident. That does not mean that the police will not try to partner with you and help in some way. Often they can come into the community and help you try to ensure safety, get their report together to collaborate with an APS investigation. This, of course, requires an abuse investigation, making sure that everybody is kept safe. But then you're dealing with a potential for an involuntary discharge based on danger to others. And so you would want to start that documentation about why you believe that this is not a behavior that can be mitigated. For example, it's not due to cognitive decline. This is a prior behavior, or it is due to cognitive decline and no interventions have worked. You cannot isolate this individual, keep them from being ambulatory, whatever your reasons are that you think they are a danger to self or others. And then you would have to go through the usual process of involuntary discharge while at the same time securing the individual away from everyone else. I have personally dealt with this. It ended up being a multi-year one-to-one caregiver assignment, 24 hours a day, paying for an individual to manage a sexually aggressive person. Unfortunately, they were also sexually aggressive with my staff. And so it just was a constant horrible situation. But we kept other people safe. And there was no other level of care for this individual to go to, and jail was not going to work for someone who needed 24/7 ADL management. So this is often a rock and a hard place situation. Bottom line is we are the catch-all with state and federal funding being allocated in our direction already and not allocated many other places. We are usually the catch-all for people that have nowhere else to go. So I hope that has responded to your question adequately, and I think that was all. I think that was all. I just had more regulatory references for you here so that you understand the contents of the notice. And then these are the people who it goes to, and you'll see why I messed up those slides. And this is the process for the notice, which you all shouldn't have to be so much a part of. And I did want to articulate for you in writing that if there is a change, you do have to reissue the 30-day. And I know that was extremely fast, but I was trying to get us caught up on time. And I think we're still a bit over. Thank you so much, Rebecca.
No, that's a lot of information in a short amount of time. Jenny, I always appreciate you because I learn something every time you present to us. So thank you for sharing that with us. That was really good. Does anyone else have any other questions before we move on? That was beefy, is what Val said. Yes, it was. It was good. All right, well, perfect. I think our next section is for Dr. Gahm. We always like to invite him to give us a little update on viruses and all things viruses in the fall. So we appreciate you telling us what's going on.
Yeah, actually, I'll make this really quick. The things we're concerned about COVID, of course, it's actually on the decline. We're seeing fewer cases now than we did a couple weeks ago. Most of what we're seeing now is, I don't know that anybody even wants to know this, but HV.1, which comes from its predecessor EG.5, which comes from Omicron XBB 1.9.2. It's just a family affair. The important thing to note is that the new vaccine covers this line, and it appears that it's covering it pretty adequately. It is a good vaccine to have. So there's that. And that's COVID. And, there's just so many questions about COVID when you get outbreaks, because we've had lots of outbreaks recently. At this point, you can call the health department, and you should, and you have to report it. But there's just a lot of common sense. Wear masks, try to keep people apart, do the isolation you need to do. The rules didn't change just because we decided on May 10th that it had gone. That's COVID. RSV, we haven't seen a lot this year, which is really nice, but the vaccine for those over 60 is still available. It requires a clinical decision-making model with the provider. So it isn't really a medical director write a standing order. Everybody over 60 gets RSV. It really does require, and it's not even the provider saying, talk to this patient, and if they want it, give it to them. The way that it was approved, it really requires the provider to have that conversation, why it might be a good thing or not, over age 60. But there's that. And then influenza, if you live in Alaska or Puerto Rico, right now, there's a lot of it. And if you don't live in Alaska or Puerto Rico, there's not very much. In Colorado, we're maybe higher than most of the states surrounding us, but we're still at the minimal level. And if you can think of this as 5 different stages, we're at stage 2, DEFCON 2, so not very much there. I am more encouraged that we seem to be getting more people vaccinated this year than we did last year in facilities. So maybe some of the vaccine hesitancy is wearing off. And that's about it, unless there are questions.
Well, I have a question. I know, Greg, you always emphasize kind of knowing the subtype of the influenza. And I was wondering, what is that significance to know what type it is?
Yeah, I mean, for our patients, H3N2, until we get 3 years from now, we have a major pandemic with H2N2, which isn't in the vaccine, hasn't been for 30 or 40 years. But really, H3N2 is the one that hits our patients. The 2B, influenza B, are always in the background year-round. So you'll see sporadic cases of it. And H1N1 is primarily a disease, a variety that hits adolescents and children. It's not typically a big problem in our folks. It doesn't mean it can't be, but it's not. It's H3N2 that we worry about that causes 99% of the problems in our population. And it looks like it's a good match this year.
Hey, Greg, could I we're here at Telligen combing through some of our data, and hasn't been finalized yet, but it looks like, so we see a discrepancy in the care compare data and in the Telligen data, because we're only able to see people who received the flu shot. The care compare data includes people that were offered and declined. So that's not counted against the nursing home. And I guess the surprise for me was that we're seeing a good 20-25% declined rate, or maybe had allergies. And I feel like that's high. So please know that Telligen is here for you, that there's tools and resources for motivational interviewing, and the CDC has a guidance for how to approach this conversation with vaccines. It just seems like that's a pretty high rate. What do you think?
Well, it is high. And if this had been 2019 or 2018, that would be just unacceptable. I think last year we were probably closer to 35 to 40%, maybe even 50% in a lot of facilities. So 25% to me sounds like a pretty good improvement. I think we're headed back to where we were 5 or 6 years ago at 85 to 90% was pretty standard. Yeah, I mean, people are gonna miss out. And again, I think one of the things that we continually forget to emphasize is that the purpose of these vaccines is not to prevent the disease. It's to prevent it from being serious. So you can get vaccinated and you can still get influenza and you can still have symptoms, but you're a whole lot less likely to be hospitalized or get really sick and die. And that's the purpose of these vaccines.
Oh, can I just chime in? I agree with everything everyone said. One of the things that I found useful for promoting the COVID-19 vaccine is to not call it a booster, because it's not a booster. It's a new updated vaccine, and it's going to protect you. You don't have any further, unless you've gotten a COVID-19 infection recently, you don't really have that protection. And so really explaining to people that this isn't a boost for something you already have. It's new and updated, just like we need a new flu shot. And sometimes that's been really helpful for people to understand. And I also put in a great article from Scientific American that kind of talks about the passive positives, people who would get the vaccine in your facilities, but they need a little bit of help, and how to help them. Thanks.
Great information, Leslie. Good reminder.
Yeah, thanks for sharing that. It's really about like how you talk to people and how it's worded. So I love that way to frame it. So perfect. Is there any other questions regarding anything on flu or COVID or RSV? If not, we're going to move on. I am next on the agenda. So we're going to be talking about hold parameters for blood pressure medicines. I am not an expert in the field, but this was a great learning process for me. And so I just wanted to kind of share what I found, which honestly wasn't much. So I need to figure out how to share my screen. So we're going to go ahead and do that for me. Sorry, y'all. Okay.
You're sharing now. Yeah.
Oh, perfect. Thank you. Always like blocks the top, so it's hard to see sometimes. So I just made a few slides so we can kind of run through it really quick. So some of the questions that kind of came up as we were talking about this as a board too, is kind of looking at these hold parameters, because CDPHE was kind enough to bring this up to our attention. These are things that have been cited in facilities, mostly because they're sometimes hard for staff to follow, especially if like you have really, strict parameters written, they're not followed, and then you can actually be tagged if you are not following the parameters that you've written out for your residents. So really it is kind of the standard of care in the hospital, like most blood pressure medicines. And I'm thinking that maybe that's where this started, because when I started doing post-acute care, it seems like everybody had hold parameters in place. So this kind of purpose of this talk is just to kind of, what is the standard of care in our setting? And then perceived benefits, disadvantages, and then also just talking about some associated risks. So
Rebecca, we're looking at your notes slides, not the.
It's not helpful for you.
Well,
I'm sorry.
It's just smaller than would be, not sure.
Hold on. See, I always like to say I'm Gen X, and so I really honestly, hold on, let's see if I can get in. But I'm really quite bad at all of this. So
if it doesn't work, it's okay.
Okay. Well, I can send them out afterwards too. So I don't know if you guys can see it. I'm going to try to zoom in. Is that helpful? Can you guys at least see it from there?
The menu at the top has an element that says slideshow about halfway across.
Okay. From beginning, current slide. We'll try that. Did that work? Hold on 1 second. I'm going to unplug my computer.
I think your share screen needs to just be changed. So if you point to the shared screen, but that's okay.
Yeah, I think that if you go to display settings, you can fix it.
Okay.
Just right up on top.
Sorry, y'all. I'm
That's
Okay, sorry, I
okay.
think I shouldn't have said anything.
Oh, it's okay. I'm not surprised that I don't know how to operate this.
It's okay.
I'm not, I feel like, your grandparents when you're Zooming with them and you can't quite get it right. That's about where I'm at with technology. So well, I'm just going to keep going just for the
It's high
sake.
level.
We'll just kind of go over it. But basically, I didn't find much information. So I tried to look through JAGs. I looked through the JAMDA articles. I really came up with one article that talked about, is it safe to discontinue whole parameters? And this first article that I found it only had 37 residents included in the study. So it was very, very small. It was one whole paragraph. And what they found is that they went through, they evaluated all the residents, and there was only 5 of them that they kept them in place for. And ultimately everyone did fine. So, and then the other article I found, which you probably can't see because I'm not sharing my screen right, talked about what the ideal systolic blood pressure is for patients in our setting specifically. It was a huge study done at the VA over years, and it had over 30,000 patients in it. And so basically, our patients are kind of need the Goldilocks blood pressure, right? They need that systolic to be between 110 and 150. And when they drop below the 110 range, they have an increased risk of cardiovascular and just risk and mortality risk. So, and that is in my practice, I've always pretty much done that. We kind of set them at 110. Sometimes the heart failure patients, they always trend low. So we would set the parameters at 90. But when I was talking with Dr. Gahm about this, he brought up a really good point is are our blood pressure parameters changing our management? Because we don't have a lot of literature to back us up sometimes in the work that we do. How often are we reviewing the blood pressure history for the residents, looking at all the vitals that are obtained? And how often are you reviewing the med reconciliation forms to make sure that when these blood pressure meds are being held? And that sometimes doesn't happen, I feel unless it's brought to your attention or you see something off in the chart. So, and then when you are looking at these things, how often are we actually stopping the medications or making changes? So it's, it is a lot of work for staff to do. And is it actually practice changing, and does it have outcomes for patients that even matter? So, my personal story, and I would welcome, and at the end of this, we'll welcome everybody to kind of give their input and any thoughts that they have, because I don't have a distinct answer for everyone, but we did it actually in the height of COVID. So here, I might actually just unshare my screen here. I'm gonna stop sharing. So we just go back to this. In the height of COVID, one of my buildings was just struggling. They could not, we were so short-staffed that it was really impossible for these CNAs to sometimes get twice daily blood pressures on patients. And these were a lot of the long-term care residents. So we spent a couple days, as there's a nurse practitioner and myself, and we went through a ton of residents' charts and looked at their blood pressures, looked at the meds that were being held, and ultimately I don't have numbers, but we discontinued the whole parameters on the majority of the residents that we had in long-term care, and everyone did just fine. So that is my real world experience, and that kind of changed my thought process to it. That, especially in long-term care, you'll see when we send out the slides, that these are chronic stable patients. We are working in the outpatient setting. So often I think in those long-term care residents, it may not add value to their care. And then we don't have a known standard of care. So we just kind of have to figure it out as we're going and make it, patient-centered. And then if we do use these, I would advocate for maybe using a shorter time frame for them. You're monitoring closely for 2 weeks, and then you're going to follow up and maybe look at the blood pressure again, so that it's not just a continuous thing that staff are doing all this work and we're not looking at it critically as a follow-up. So those were my thoughts, and I would welcome anybody else who's had experience with this or is trying to change their practice, because I think it is a hard thing to get away from. Singh brought up a really great point that when she started, like her nurses were like, well, you better put whole parameters on these. And I still get those phone calls all the time. It's hard to break that habit. So does anyone else have any thoughts or input?
I think that for me, the hold parameters are kind of a little band-aid for just for that moment. If the blood pressure is a little soft and someone holds the medicine, maybe it'll just make a difference for that one day. But we're trying to look at more long-term management of the medications. We want to know what the trend is for the blood pressure and the heart rate. And if without knowing which days the medicine was held or not, it could be very variable. It does actually make it harder to titrate.
You know, along those lines, one of the areas that I've always had difficulty with is the clonidine for systolic blood pressure greater than 180. Because occasionally people will have, they'll have lower blood pressures, they're going to have elevated blood pressures, so that one shot could actually be potentially dangerous for some of our residents. So.
No, I
agree with that. This is Dave Shepard. Sorry. Yeah, I think along that line, actually, I think there's some hospital data showing that PRN use blood pressure medications actually increases morbidity and mortality.
Yeah, I've seen that as well. I agree with the conversation. And I think the most telling thing is that we are holding medications and often we are unaware. We're not kind of following up on these whole parameters. So everyone's doing all this work and we're not following through. So I'm not sure of the usefulness of, these parameters at all. Thanks.
I will share that when I was a nurse way back when at Mass General, I once asked a house staff for parameters and they gave me a hard time. So it's unchanged for the last 40 years.
Perfect. Well, good. Then maybe I feel a little bit better about my struggle with it. But I totally agree with the clonidine that we've gotten on surveys before. I've had trouble with that one specifically because what happens is that the patient's blood pressure gets checked that morning and it's 185 before all the regular blood pressure medicines have been given, and so they give the regular blood pressure medicines plus the clonidine. So if you're not really specific about saying, well, you need to check the blood pressure at noon, and if it's this, then you give the clonidine. You have to be really specific about your orders, otherwise that can really get you into trouble. So,
and there's a comment from Danielle in the chat box about how the other consideration is the opportunity cost. Performing the routine blood pressure may be pulling the staff away from doing something more valuable, which we saw in your case, Rebecca, in your facility.
And we were honestly having a lot of trouble just communicating those blood pressures to the nursing staff. So even though it feeds into the EMR, nurses may not be looking, the CNAs aren't communicating. There's a lot of missed opportunities there. And it's hard when everybody's struggling just trying to get their work done. So Val says it gets tricky with medication adherence if they are on and off again, which is totally true. Sarah mentions that one of my homes for tag release the year got a tag for not having hold parameters for blood pressure medications. So that's an experience.
Yeah, that takes me to, we have a lot of clinical expertise we've shared, but we've got Chad and Joe here. Help us with the regulatory side of this.
What I was going to say was I'm really glad you had this discussion, as you know, because historically we've always had to cite it because that's our guidance. But I think that we can continue this conversation, and Chad and I can have a conversation and look at the regulatory, look at our regulations and really see what we can do to help support the things that you're saying and help support each individual resident and make it more person-centered and not necessarily one size fits all. So give us that opportunity to do that, and then maybe at least at the next meeting we can maybe have further discussion and come up with what we've been able to do as far as regulations. Chad, do you have anything else you might want to add about that?
Those were my thoughts exactly, Joe. I think we need to look at the person-centered nature. What makes sense this, and is this a long-term situation for the individual, and they're stable, and you know, that we can give consideration to those kinds of details.
Mhm. And kind of on the nursing side, I know that nurses are held to a standard. You're not meant to give medications physically to someone unless it's safe. And maybe the argument is, how do you know if it's safe or not if you don't check the blood pressure? But that I think it does come down to knowing the patient, and if they are stable, and the plan is to do some long-term management of the meds, not a day-to-day management of changing the medications, then it makes sense just to give it as prescribed until the orders are changed. But I could see perhaps from a nurse standpoint wondering, what do you do if there aren't any parameters?
And I'm sure there's an element of, I mean, that was kind of one of the questions that came up for me too, is like where nursing judgment comes into play, you know, like I think that's hard too. And I'm definitely not a nurse. I mean, Karen, you're a nurse, a former nurse.
Yeah, so yeah, when I remember when I was training, we had parameters. I mean, we had to know the medications that we were given. And clearly, if a blood pressure was low, we were going to be given that medication. That was my understanding from my nurse practicing. But
so I do think it kind of takes the team. I mean, it's always takes a team. Geriatrics is a team sport, right? So making sure we're working together and communicating well with each other if we are discontinuing things, and so that the staff can feel confident in that. So, well, thank you for the excellent discussion. That was fantastic. And thank you, Joe and Chad, for kind of looking that over and giving us feedback on it. We appreciate it. So, all right. And I'm sorry about the slides, y'all. We'll send them out. You'll get the link. All right. Well, I don't have anything else. Is there anything else from the group that we'd like to cover before we give you a few minutes of your day back?
Just as an FYI, I will send the surveyor critical element pathway to you all as an attachment for the education then with regard to medication administration, so you can see what exactly a surveyor is asked to look at.
Oh, perfect.
That'll be helpful. Yeah.
All right. Well, thank you so much for coming today, and we look forward to seeing you again next week or next month. Sorry. But have a great holiday season, everyone. Thanks for being here today.
Thank you. Want me to stop the recording?
I was going to say I can stop now, can't I? So not.
Sir, do you see them?